Imagine you are, 20 miles into a marathon.
Oh, yeah, that walls.
Right. But your pacing is actually perfect. Your knees are holding up. Your lungs feel great. But with every single stride, you are in just absolute agony from an injury that you cannot wrap.
Mm.
You can't brace it. And it's one that nobody in the running world actually talks about.
Yeah, they really do. It's completely ignored.
Right. So today we're looking at this really physical, functional injury landscape that is just shrouded in silence. We're talking about the anatomical reality of what high-impact repetitive motion does to the female body.
It really is the absolute definition of an underserved clinical reality, honestly.
Yeah.
Because the condition we're talking about is severe vulval skin chafing.
Yeah.
It's often colloquially referred to as sports vagina.
Which is such a blunt term, but it fits.
It does. And, while athletes are incredibly vocal about things like plantar fasciitis or IT band syndrome, right?
Oh, sure. Yeah. Everybody knows about runner's knee.
Exactly.
Yeah.
But the intense friction that's occurring to female anatomy during a marathon or, say, a 100-mile cycling race, it just remains a taboo subject. Even in sports medicine clinics, women hesitate to bring it up.
And that is exactly why we pulled together this specific stack of sources for our deep dive today. We're diving into clinical trials, some really detailed anatomical reviews, and even cosmetic gynecology guides.
Which sounds like a strange mix at first.
Right. But the mission today is to understand how these highly active women are utilizing regenerative medicine to treat this intense friction. Because when I was reading through this stuff, I realized we are looking at this really profound intersection of sports medicine, the natural aging process, and, well, structural restoration.
Right. Structural is the key word there.
Yeah, because this is not about aesthetics. It's not about vanity.
Not at all. It is entirely about restoring functional physical comfort. We're essentially evaluating medical treatments that are designed to allow an athlete to move without just debilitating mechanical pain.
Right.
But to understand how these treatments actually work, we kind of have to look at the underlying physiological mechanisms of the injury itself first.
Yeah, because the tissue damage doesn't happen in a vacuum.
Exactly. It happens because a natural biological protection system has basically failed.
So let's look at that biological protection system. I mean, the best way I could think of it when I was reading the sources is, well, if you think about a car.
Okay, a car.
Yeah, so you have the delicate, highly complex engine parts, right? And then you have the shock absorbers.
Mm-hmm.
And the shock absorbers take the impact from the road so the engine doesn't just get rattled to pieces on a bumpy street. In the female anatomy, the labia majora, so the outer lips, they serve as those natural shock absorbers.
That's a really great analogy.
Yeah.
Because anatomically speaking, the labia majora are heavily composed of connective tissue and subcutaneous adipose tissue.
Which is just fat, right?
Yes, exactly. It's just fat. But functionally, their primary evolutionary job is to act as a protective cushion. They exist to shield the much more delicate internal mucosal structures. So we're talking about the labia minora, which are the inner lips, the vaginal introitus, and crucially, the clitoris.
The sensory data in our sources regarding the clitoris, it really puts this need for protection into perspective.
Oh, the nerve density is wild.
It is, because there are these recent synchrotron mapping studies, and they show that the glands of the clitoris contains over 10,000 sensory nerve fibers.
Right. 10,000.
You map 10,000 nerve fibers onto a structure that small, I mean, the density alone dictates that it just cannot withstand direct mechanical trauma.
No, it can't. The relative density is astonishing. To put it in anatomical terms, that is a nerve density roughly 15 times higher than that of the gland's penis relative to its size.
Like 15 times?
15 times higher, yeah. It is heavily packed with these highly specialized nerve endings that are designed to be exquisitely sensitive to the lightest touch or pressure.
Okay.
So because of that extreme neurological sensitivity, it relies entirely on the surrounding anatomy. It needs the clitoral hood and the bulky, fat-filled padding of the labia majora for protection against just constant, everyday environmental friction.
But over time, those biological shock absorbers, they can basically deflate.
Yes, they really do.
The sources use the term hypotrophy or atrophy, and they detail how the labia majora basically function as a facial analog. So they age identically to the skin on our faces, relying on that same subcutaneous fat and a robust collagen matrix to maintain their volume.
Exactly. The cellular degradation is identical. Due to the natural aging process or sometimes genetic predispositions or even significant weight loss, the body just stops synthesizing collagen at the same rate.
Right, things just sort of slow down.
They do. Furthermore, when women experience drops in estrogen, particularly during perimenopause and menopause, it triggers a loss of that subcutaneous adipose tissue.
So the fat goes away.
Yeah, the fat cells literally shrink, or they undergo apoptosis, which is cell death. So the labia majora lose their structural integrity, and they just deflate.
And when they deflate, the sources describe this resulting anatomical shift as an unveiling.
An unveiling, yes.
Which sounds kind of poetic, but functionally it's terrible because the protective cushion recedes, which means the labia minora and the clitoral hood are no longer safely tucked behind full outer lips.
Right. And the mechanics of the chafing become completely inevitable at that point.
Really?
I mean, consider the physical reality of an endurance runner here.
Okay.
She goes out for a 10K, taking roughly 170 to 180 strides per minute.
Which is thousands of impacts.
Exactly. Or, she clips into a spin bike for an hour, and she's wearing tight compression gear.
Yeah.
Or yoga pants. Because that outer padding is gone, every single stride, every pedal stroke, it generates direct, unmitigated friction against highly sensitive, unprotected mucosal tissue.
It completely makes sense why athletes call it sports vagina. I mean, the delicate inner mechanics are taking the entire brunt of the biomechanical impact.
Yeah.
But if the outer padding is gone, I imagine the first line of defense isn't, immediately surgical or medical. Like, athletes are probably trying to manage the surface level fallout of that friction first, right?
Oh, absolutely.
Yep.
The initial interventions are always conservative. We're talking over-the-counter remedies.
Like creams and stuff?
Yeah. The immediate goal is just to soothe the irritated tissue and artificially replace the physical barrier that the labia majora used to provide. So athletes heavily rely on hydrocortisone creams, for instance.
Just to get the swelling down.
Right. Exactly. To suppress the local immune response and bring down that immediate inflammation. They will also apply thick, occlusive barrier creams like Vaseline.
Right. Classic runner's trick.
Yeah, just to artificially reduce the coefficient of friction between the skin and the fabric.
But the friction isn't just a physical annoyance, is it? I mean, reading the sources, it's actively destroying the local tissue ecosystem.
It really is.
I was absolutely fascinated to read about how this mechanical trauma kind of cascades into a microbiological problem.
Oh, that's a huge issue.
Because when constant friction creates micro tears in the tissue, it disrupts the skin's natural acid mantle.
That cascade is a critical component of why this is so uncomfortable. So, healthy vaginal and vulvar tissue maintains a highly specific acidic pH.
Okay.
And that's largely regulated by beneficial lactobacilli bacteria.
Right.
But when repetitive athletic friction causes microabrasions, the skin barrier physically breaks down. And blood and serum, which are slightly alkaline, weep into those micro tears.
Oh, I see. So without that acidic shield, the local pH just spikes,
Exactly.
creating the perfect alkaline breeding ground for opportunistic yeast and bacteria to basically just take over.
It creates a highly compromised environment, yeah.
Yeah.
The tissue is already mechanically inflamed from the running, and now it is highly susceptible to secondary bacterial or yeast infections.
Just sounds miserable.
It's awful. To combat this, sports medicine protocols often incorporate specialized vaginal moisturizers.
Okay.
So products containing hyaluronic acid, like Miavita gel, are commonly utilized.
I want to pause on hyaluronic acid for a second, actually,
Yeah.
because it comes up a lot in these treatments, both topical and injectable. And instead of just coating the skin, like Vaseline does, hyaluronic acid is a humectant. It's a naturally occurring sugar molecule in our bodies that acts like this microscopic magnet for water.
Right.
I think the sources said it holds up to 1,000 times its weight in moisture.
Yeah, it's incredibly effective at hydration.
So using it topically draws hydration back into that damaged tissue while also helping to rebalance the local pH, right?
Exactly. And athletes will often pair that topical hydration with internal support,
Like what?
like taking an oral probiotic formulated specifically for the vaginal microbiome.
Okay.
For example, something like Happy V's prebiotic and probiotic. That introduces targeted bacterial strains into the gut that eventually colonize the vaginal flora.
Oh, interesting. So it's sort of a two-pronged attack.
Exactly. This supports a healthy ecosystem from the inside out, making it vastly more difficult for opportunistic infections to take hold in skin that is already, battered by running.
But I mean, if creams and probiotics are just kind of putting out the surface fires, they aren't rebuilding the house.
No, they're not their management.
Right. They manage the inflammation and the infection risk, but that loss of anatomical volume, the deflation we talked about, is still there.
Very much so.
Which brings us to the medical interventions. I mean, how do you actually replace a biological shock absorber?
That's the big question.
My initial assumption, just based on general cosmetic knowledge, was that a labiaplasty would be the standard procedure for any labial discomfort. Like, you just surgically trim down the inner lips so they don't rub against the yoga pants.
And see, that is a pervasive clinical misconception.
Really?
Yes, and it perfectly highlights why precise anatomical assessment is so important.
Okay, unpack that for me.
So labiaplasty involves surgically excising or cutting away the labia minora.
Inner lips.
Right. Now, if an athlete has a specific genetic predisposition where her inner lips are naturally very elongated and they're getting physically caught in clothing or bicycle seats, then a labiaplasty might be the appropriate structural fix.
Right, that makes sense. But if her discomfort is caused by the deflation of the outer lips, due to age or estrogen drops, cutting away the inner lips doesn't address the pathology at all.
Not at all.
It's like you wouldn't cut away the engine parts just because your car's shock absorbers wore out.
That is exactly it. It would be an entirely misdirected surgery. The root cause is a loss of outer padding, not an excess of inner tissue.
Right.
Therefore, the paradigm really shifts from excision to augmentation. Adding volume back to the labia majora is the far more precise functional cure for this specific mechanism of injury.
So let's break down the mechanics of this augmentation arsenal. Because our sources detail 3 primary methods for rebuilding this padding.
Yes, they do.
Starting with the one that's most prevalent in facial aesthetics, which is injectable hyaluronic acid, or HA fillers.
Right, the HA fillers.
These are products like Deserial Plus or vaginal filler or Primavera. And I imagine HA is incredibly popular here since it's typically an in-and-out office procedure.
Very much so.
And because it acts like that microscopic water magnet we discussed earlier, it's not just adding physical padding, it's actually pulling intense hydration deep into the mucosal tissue.
Yeah, the clinical utility of HA fillers is substantial. I mean, they provide immediate, visible volume restoration.
Like right away.
Right away. And the procedure is minimally invasive. It's usually performed under local anesthesia right in a physician's office.
Oh, that's convenient.
Extremely. Furthermore, because these modern HA gels are of non-animal origin, they're typically synthesized via bacterial fermentation, they carry an exceptionally low risk of immunogenic or allergic reactions.
Okay, that's a big plus.
And that tissue hydration benefit you mentioned, that is a major factor for menopausal athletes who are dealing with concurrent vaginal dryness.
Okay, so the sources present a very compelling case for HA. But I want to introduce a strong counter-argument from the clinical notes, specifically from Dr. Poucher.
Ah, yes. Dr. Poucher's pushback.
Yeah, because she strongly advises against using HA fillers in the labia majora. And her reasoning gets right to the heart of how this specific tissue behaves differently from, say, the tissue in your cheeks.
It does. Dr. Poucher's clinical pushback is essential for really understanding the nuance of vulvar anatomy. She points out that the labia majora are highly mobile and incredibly vascular.
Meaning a lot of blood flow.
Exactly. There is a very dense network of blood vessels and lymphatic drainage in this specific area.
And she zeroes in on the exact mechanism that makes HA so popular, which is its ability to attract water.
Right, the humectant property.
Yeah. So if we visualize HA as this microscopic sponge implanted into highly vascular tissue, what happens during times of systemic water retention? Like when a patient eats a heavily salted meal, or maybe during the premenstrual phase of her cycle?
It's a problem.
That HA filler will aggressively soak up all that extra circulating fluid, right?
Yes. The consequence of that sponge effect in this specific anatomical region can be severe.
Oh, wow.
Yeah, the vulva swells significantly, becoming engorged and causing immense physical pressure and discomfort. Essentially, the artificial shock absorber uncontrollably inflates.
That sounds absolutely terrible for a runner.
It would be. So Dr. Poucher argues that for patients experiencing severe deflation, a labia majoroplasty is superior.
Wait, majoroplasty, not labiaplasty.
Right. Majoroplasty is a surgical procedure where the physician physically excises the excess stretched-out skin of the deflated outer lips, and then they pull the remaining tissue taut to tighten the area naturally.
Okay, so just removing the extra slack.
Exactly. Without introducing any foreign water-retaining volume.
But so if an endurance runner wants to restore volume and avoid the surgical downtime of a majoroplasty, but they also want to avoid the sponge effect of HA fillers, what is a biological alternative?
Well, that brings us to method number 2.
Biostimulators.
Yes, biostimulators, or extracellular matrix fillers.
Mhm.
The sources mention materials like polylactic acid, that's PLLASCA, and calcium hydroxylapatite, CHACMC.
Okay, lots of letters there. But the mechanism of action for biostimulators is entirely different from hyaluronic acid. Right?
Completely different. So instead of depositing a gel that simply sits in the tissue and holds water, biostimulators are injected as a suspension of microparticles.
Okay.
And these microparticles act as a physical and chemical scaffold within the tissue.
Oh, I see. They essentially trick the body into doing the work itself.
Basically, yeah.
I see it like the difference between planting a sponge and planting seeds.
Oh, I like that.
Yeah, so the HA sponge just absorbs water for instant padding, but with biostimulators, you are planting seeds or maybe putting down a trellis, and you're triggering the body's immune response to grow its own natural padding over time.
That immune-mediated response is the key here. The
Mhm.
body detects these microparticles and triggers a controlled subclinical inflammatory response.
Right.
This activates local fibroblasts. Those are the cells responsible for a structural framework,
Okay.
and it forces them to synthesize dense, new, natural collagen and elastin all around that scaffold.
Wow.
Yeah, and because this new volume is composed of the patient's own native collagen, it does not rely on attracting water.
Which completely bypasses Dr. Poucher's concern.
Exactly.
You don't have to worry about sudden, painful swelling during PMS or after a marathon where the athlete might be retaining a bunch of fluids.
No sponge effect whatsoever. Furthermore, the longevity is superior.
Oh, really? How long does it last?
Well, while HA fillers might degrade over 6 to 12 months, the structural neocollagenesis induced by biostimulators often lasts 12 to 24 months.
Wow, up to 2 years.
Yeah, providing a highly durable cushion for rigorous athletic training.
That sounds like a remarkably elegant solution for someone who's constantly subjecting their body to mechanical stress. But there is a third option detailed in the surgical guides, right?
Yes, there is.
It seems like the most permanent structural fix of all, which is autologous fat grafting. And autologous simply means the material comes entirely from your own body.
Correct. So the procedure involves a localized mini liposuction.
Okay.
The surgeon harvests healthy, viable fat cells, typically from the patient's abdomen or maybe the inner thighs.
Mm-hmm.
That adipose tissue is then centrifuged to purify the fat cells. Then it's carefully re-injected in multiple fine layers into the labia majora to essentially rebuild the structural volume.
My immediate thought reading this, though, was about the patient demographic.
Oh, so.
Well, if someone is an elite endurance runner or a triathlete, they typically have an extremely low body fat percentage to begin with.
Oh, absolutely.
So finding enough viable donor fat might actually be a physical limitation for this specific group, right?
That is a very legitimate clinical hurdle. Fat grafting requires sufficient donor sites. If you don't have the fat to harvest, you can't do the graft.
Right.
Additionally, the recovery and stabilization period is longer than with injectables.
Because it has to survive the move.
Exactly. Not all the transferred fat will survive the grafting process. The body typically reabsorbs a percentage of it over the first few months before the final volume really settles.
Okay.
However, for those who are candidates, the benefits are profound. You are providing completely natural, permanent padding without introducing any synthetic materials or chemical biostimulators at all.
And the sources highlight a secondary regenerative mechanism with fat grafting that I thought was fascinating. It goes beyond just adding mechanical bulk.
Yes, it has to do with the composition of the fat itself.
Right, the stem cells.
Exactly. Adipose tissue is inherently rich in adipose-derived stem cells.
Okay.
So when a surgeon transfers that fat to the vulvar region, they are actively introducing regenerative properties into damaged tissue.
Wow.
These stem cells promote angiogenesis, which is the formation of new blood vessels.
Oh, neat.
Yeah, and it significantly improves the actual cellular quality, the elasticity, and the overall health of the overlying mucosal skin that has been just battered by years of chafing.
Okay, so we have the anatomical pathology, the biomechanics of the chafing, and we have the chemical mechanics of the material. So HA, biostimulators, and fat.
Mm-hmm.
But what is the actual lived experience for the patient? If an athlete decides to undergo one of these procedures to get back out on the track, what does the clinical efficacy and safety data actually look like?
The clinical literature is highly encouraging. Specifically, if we look at the Isolane study and a recent, really robust randomized controlled trial involving 76 women.
Okay, 76 women, that's a good sample.
It is. And these procedures are proven to be highly effective and remarkably well tolerated by the patients.
I was specifically looking at the pain metrics during the procedures because, well, that's always a barrier to entry,
Oh,
right?
of course.
In the randomized trial evaluating HA injections, the average pain reported during the procedure was just 1.4 out of 10 on the numeric rating scale.
Yeah, a 1.4 on the NRS signifies barely perceptible transient discomfort.
Barely anything.
Right. To contextualize that for an athlete, the localized pain of an active chafing lesion during a run, or even the discomfort of a deep tissue physical therapy massage, typically scores significantly higher on that same scale.
So the procedure itself is just a minor hurdle.
Very minor.
But I'd imagine the more critical metric for a runner is the recovery timeline. Like, if an athlete is actively training for a half marathon, how much time is she losing by getting her anatomical shock absorbers rebuilt?
Well, for the minimally invasive injectables, the downtime is surprisingly brief.
Really?
Yeah, normal, light daily activities and walking are perfectly fine within 24 hours.
Oh, wow.
But the strict limitation is on high-impact mechanics. So athletes must absolutely avoid running, jumping, spinning, heavy cycling, and sexual intercourse for a window of 1 to 2 weeks.
1 to 2 weeks. I assume that's because the filler material, whether it's the HA gel, the biostimulator particles, or the grafted fat cells, it needs time to physically integrate into the tissue matrix, right? Because if you immediately subject the area to 180 strides a minute, you risk migrating the product before it even stabilizes.
Yeah, the mechanical shear forces of running would easily displace the material.
Makes total sense.
But once that stabilization window closes, the reported outcomes are striking. And the data demonstrates that treating the primary mechanical problem yields massive secondary benefits.
Yes, the secondary endpoints in that 76-woman trial really highlight the psychological reality of this injury.
It's a huge factor.
Because the researchers didn't just measure chafing reduction, they used the Female Sexual Function Index, or FSFI. And at the 6-month mark, women reported significantly less dyspareunia, which is pain during sexual intercourse. So by restoring the padding and hydrating the tissue, overall sexual function comprehensively improved.
And they also utilized the Global Aesthetic Improvement Scale, or GAIS.
Right.
And while our focus here is on function, the psychological impact of anatomical restoration cannot be understated.
Of course not.
The scores showed massive boosts in how women perceived their own bodily proportions.
And the sources explicitly note that women stopped avoiding certain types of clothing.
Yes.
They were finally putting on yoga pants or swimsuits without this persistent underlying of impending physical discomfort. It completely shifts how they interact with their environment.
It really reveals the profound holistic impact of regenerative gynecology.
Yeah.
When a physician successfully treats the physical friction and the mechanical pain of sports vagina, they are simultaneously healing a massive psychosocial burden. The patient is no longer alienated from her own anatomy.
Right.
She stops dreading the physical cost of her workout.
She gets to reclaim the joy of movement. The endurance sport stops being a battle against her own biological degradation.
Very well said.
So, to bring all the threads of our deep dive together today, we started by exploring the specific anatomy of deflation. We looked at how the labia majora function as the body's natural shock absorbers, utilizing fat and connective tissue to protect the hypersensitive 10,000 nerve fiber structure of the clitoris.
Right.
And we saw how age, genetic factors, and estrogen decline cause that padding to atrophy.
Which, as we discussed, mechanically unveils that delicate mucosal tissue, leaving it completely unprotected against the repetitive shear forces of high-impact endurance sports, resulting in severe chafing, microbiome breakdown, and localized pain.
And from there, we examined the medical interventions. We looked at how regenerative medicine is stepping in to rebuild that functional cushion, whether it is through the hydrating sponge effect of hyaluronic acid, planting the scaffolding seeds of biostimulators to grow native collagen, or utilizing the regenerative stem cells in autologous fat grafting. The takeaway from the clinical data is clear. These procedures are not about chasing anti-aging vanity. They are fundamentally about optimizing physical comfort, tissue health, and athletic longevity for active women.
Exactly. By addressing the structural root cause of the friction, these treatments provide female athletes with the functional anatomical support necessary to continue performing at a really high level without enduring silent, normalized pain.
Which brings me to a final thought I want to leave everyone with.
Okay, let's hear it.
Well, we have spent this entire time analyzing these treatments as a reactive cure, right?
Hmm.
A medical intervention for a mechanical problem that has already caused severe discomfort.
Right.
But looking at how effectively minimally invasive biostimulators can trigger our own fibroblasts to reinforce the body's natural anatomical padding, but targeted preventative tissue biostimulation eventually become a standard part of a female endurance athlete's training toolkit.
Oh, wow.
I mean, if we know the biological shock absorbers are going to degrade with age and repetitive stress, why not proactively reinforce the tissue matrix before the delicate internal structures take a hit?
That is a really interesting concept.
It is certainly a new paradigm for athletic conditioning, and definitely something to consider next time you lace up your running shoes.